really pleased to introduce our OHCOW Winter 2022 session, COVID Conversations, Critical Concepts in Ventilation and Viral Evolution. So really, we've got a double bill this afternoon, and thanks for joining. The two important topics are indoor air, public health, and COVID-19. And we also want to have a second session, the science of mutation, variant risk and impact. So really, compounding of harm and disruption from reinfection, diverse and waning immunity, widely circulating respiratory viruses, plus increasingly transmissible SARS-CoV-2 variants. We really just can't drop the ball on this. It's more important than ever. So understanding the risks and the steps to effective transmission reduction are keys to prevention for the seasons of gatherings and festivities, as well as planning for the new year as we bring our families together in indoor congregate settings. This was presented some time ago from Gossier, Dr. Gasparitz, talking about how the variants are still mutating. And I just noticed on the conversation in China, there's some real concern there about it's kind of like a subvariant of BA5, BF7. And I just saying that there's a lot of attention on this variant as well. So just the session, the first of the two sessions, it is indoor air, public health, and COVID-19 gaps in public health guidance and a checklist for community spaces. So we're very grateful to have Amy Katz and Dr. Amy Lee present today. And really, this just builds on previous sessions. So we have had Joey Fox, Clean Air Really Matters, and that was September the 16th, and you can actually go and hear the recorded webinar. And we were fortunate to have a graphic designer, or a cartoonist, I should say, pull the cartoon on the left just to kind of give us a snapshot of that webinar. And you can actually find that through the Canadian Aerosol Transmission Coalition. And last week, Krista Thompson hosted a webinar with Joey Fox, Marianne Levitsky, and Stefan Bilodeau, and they were talking about the great work done by OPSI. So you'll see there's some very good guidance material there, and Joey presented that guidance material there, which also includes a ventilation checklist. So just, the conversation with Amy Katz, she's knowledge translation specialist at the MAP at St. Michael's Hospital, Unity Health Network, and she's an adjunct professor with the School of Cities at the University of Toronto. And we've also got Dr. Amy Lee, who's an assistant professor in the Department of Civil and Environmental Engineering at the University of Waterloo. Dr. Lee studies strategies to improve indoor air quality and reduce occupant exposure to airborne pollutants in residential and commercial buildings. And there's just a link to the ventilation guidance that's provided through MAP Health. And you'll see that Dr. Jeffrey Siegel worked closely with Dr. Lee on this document. And I just kind of put a screenshot of the site that you can go to that Amy Lee and Amy Katz will talk about as well. So the order of speakers is we've actually got Amy Lee presenting first. And I just got to get here we go. Hopefully everybody can see that. How's that look? Can you see that okay?
I think maybe you can maximize the PDF into a full screen mode.
I'm used to doing this with PowerPoint, so I can't see how to maximize this to a full screen.
It's not too bad. There was Can you make it just 66 you've got there? Can you make it like 75?
I think it may just exceed
that?
the border.
How's that? Okay. So I'm just going to hand everybody over to Dr. Lee first, and then thank you so much for presenting to us, Dr. Lee. Over to you. Thank you.
Well, thank you, Kevin, for the introduction, and more importantly, for inviting us to this conversation today. It is really our pleasure to share the information not only on ventilation, but also on the general approaches to improve indoor air quality. A little bit about the process. So first, I will just talk a little bit more about myself and why, in particular, this is one of my favorite projects. And then I'll pass it to Amy Kay to talk a little bit about herself, and then start the presentation, and then you will come back to me. So sorry about this a little bit confusing procedure, but I do want to share kind of why this project is so important for me on both a professional level and of course on a personal level. So like Kevin has mentioned, my research has been mainly focused on the impact of both filtration and also sometimes ventilation in the residential systems and also in commercial buildings. And for me, it has been a great pleasure to get involved, to share kind of the practical information about how to use different strategies to improve indoor air quality in community spaces. First of all, it is of course great to share the findings from the literature and kind of communicate with the general public. And more importantly, it is because this information is urgently needed. The improvement for indoor air quality is not only important to reduce the transmission of infectious disease, including COVID-19, but it is also very important to improve the general health and well-being of everyone who is in the buildings or other indoor environments. And from our conversations with community organizations, we have learned that many people have worked very hard and at the same time also conducted their own research to keep themselves safe and also keep everyone around them safe. So again, I just really appreciate this opportunity to create a comprehensive step-by-step guide so that we can provide a little bit of support to help the people who are already working so hard to navigate the challenges, because it could be confusing at times. So during the presentation today, Amy Kay and I will share more about what we have learned from the community, especially about the challenges and how this has guided us to design this checklist to help them address the challenges. Overall, I just want to say that I really appreciate the opportunity to work on this project and of course to share the information with everyone here today. Now I'll pass it to Amy Kay to talk about herself. Amy, you're muted.
Sorry, can you hear me now? Yeah, okay. I was just saying that was really nice to hear you say all that, Amy. Like I hadn't heard all those different perspectives on the work from you, so I appreciate that. We're always so focused on what we're doing that we don't get the chance to reflect a lot. We're a very interdisciplinary team, so it's just really fun to hear that. So I'm just going to share a tiny bit about my background because we decided to start this with what attracted us, why this work matters to us. So as Kevin mentioned, I work in knowledge translation. I work for a hospital. I'm a white Jewish woman. I grew up in North York, and I've really struggled to find an ethical place for myself in public health research. And I'm not saying that I found it, but I think that, as you'll hear, a lot of this work focuses on reducing the harm of mainstream settler institutions. And I feel like that's not necessarily an ethical place, perfectly ethical place for me to do research. It's appropriate one, as I feel responsible for a lot of these organizations and maybe some of the harms that they're doing. And we'll get into a lot of detail about that soon. The other reason I'm really motivated to do this particular project is the opportunity to work with engineers. And as you'll hear, we're also working with lawyers, and we're working with epidemiologists, and we're working with other knowledge translation experts. And what I love so much about working with engineers or people with engineering expertise is the ability to do something truly concrete. which as many work in knowledge translation realize, we don't always get the chance to do that. Often we're just summarizing evidence, handing it to policymakers, hoping it makes a difference. And as we're here, we've kind of got this applied direct program of knowledge translation going on, and it's very exciting. And because it's got such momentum, we keep sort of gathering new team members, and we keep expanding these collaborations. So we hope today's an opportunity to do that as well. Yeah, so thank you. And we're going to get right into the presentation. Kevin, could you go to the next slide, please? Thank you. So you've heard a bit about us. We're going to tell you a story about why we produced this checklist on indoor air quality and COVID-19 for community spaces, because we think the context is very important. Then Amy's going to present highlights from the checklist. We'll talk briefly about next steps, and then hopefully we're going to have some time for Q&A. Okay, next slide, please. So our story begins, oh, sorry, I'm glad I saw this. So we wanted to give you a sense of how broad our team is. So you can see that there's me, there's Amy. You can see that there's Lana, James is a big part of this, Jeffrey Siegel, and Patricia Ocampo. That's sort of our main group. We also have a research fellow. We're working with lawyers, and we can tell you more about that. And we have an amazing project manager. So we just want to acknowledge that this is a large group of people and getting bigger all the time. Next slide, please. We want to acknowledge our funder, which is the School of Cities from the University of Toronto. We also have some funding from CHR and enormous in-kind contributions from our home organizations. Next slide, please. So this whole story starts with a research question that we asked in 2021. We knew that Toronto Public Health and Public Health Toronto published guidance on how to reduce transmission of COVID-19 in congregate settings, such as shelters, group homes, and detention centers. And we just asked the very simple question, does this guidance include indoor air quality measures like ventilation and filtration? Because of course, at this point, we started this work in October 2021. And at this point, it was very well known that COVID was airborne and that ventilation and filtration had the capacity to help. So if you go to the next slide, we're going to tell you what we found when we looked at this guidance. But before that, we want to make sure that we're all on the same page with some shared assumptions. And I kind of feel like in this group, we probably are on the same page, but we don't always present to people that we're on the same page with. So we just want to make sure that we want you to know the assumptions we went in, or the facts that we went into this research with. So the first one is, by January 2021, it is known that COVID-19 is transmitted through the air. I'm sure everybody here is aware of this famous call from 239 scientists that was published in July 2020, saying to the medical community and relevant national and international bodies that it was important to recognize the potential for airborne spread of coronavirus disease. Next slide, please. As part of our research, we've sort of looked at the timeline of when peer-reviewed evidence began emerging that COVID-19 was airborne. So you can see here, these are all peer-reviewed articles that were published and made public, not as preprints, but as articles between March 2020 and March 2021. This is just a few examples. We couldn't get them all on the slide, but there are outbreak cases published in the literature, and in each one, the authors conclude that transmission was probably or certainly airborne. And you can see there's a whole variety of settings, squash courts, high-rise buildings, public transportation vehicles, the famous cruise ship, a department store, a meat processing plant, and these examples are from all over the world. So anyone whose job it is to be familiar with the literature would have seen these and many more articles within the first year of the pandemic. Next slide, please. So on top of these peer-reviewed cases, there were countless warnings in the literature, and I'm sure everybody here is familiar with these warnings. But when we actually started looking at the literature, we found far more than we were even aware of. Some of these are published in peer-reviewed journals. Some of these are Ontario-specific. So you can see this open letter in November 2020 from doctors and engineers calling on Ontario to address airborne spread of COVID-19. And that letter was addressed to the Ministry of Health, and it was also addressed to Public Health Ontario. You can see there was another national one in January 2021. So this was an international phenomenon that also happened in Ontario, and this is all within the first year of the pandemic. Next slide, please. Okay, so the next fact that we want to establish collectively is that ventilation and filtration remove respiratory particles from the air. Again, I don't think that's a controversial statement in this group, but as you know, this has taken a lot of proving over the past couple of years. Next slide, please. So again, I feel like people are going to be familiar with this literature, but there's all kinds of different guidance that was published very early in the pandemic. And that guidance really hasn't changed that much. It's become nuanced and more detailed, but it really comes down to ventilation, filtration, ultraviolet disinfection, bathroom fans, and all of this was laid out in a lot of detail, again, by the first year of the pandemic. Next slide, please. So again, not a controversial thing to say, but the other reason that we were motivated to look at these very specific settings is because congregate settings where people share spaces, and again, we want to make it really clear, it's not the people who are high risk, it's the spaces that are high risk, the spaces that are putting people at risk. So for congregate settings, such as shelters, long-term care homes, and group homes, it's particularly important that the COVID-19 guidance shared with these settings reflects the best evidence and embeds the precautionary principle. Next slide, please. So these are some really upsetting numbers. Every time we get to this part of the presentation, I have to take a breath. So by December 2021, some Ontario long-term care homes had lost more than 30% of their residents to the pandemic. This is from a data set by the independent researcher Nora Loretto. By June 2022, 11 long-term care workers, which I'm certain is an undercount, by the way, because the data is so bad, and more than 4,500 long-term care residents had died of COVID-19, constituting close to 35% of COVID-19 deaths in Ontario. Now, this is the latest data I could find from PHO, which was June 2022. I don't know if they've stopped publishing these numbers, but I feel like people in this audience might know, so it'd be great to discuss this at the end of the conversation. And I think it's really important to point out that these deaths are ongoing. They continued more than 2 years into the pandemic. Between December 15th and June 4th, 2022, 620 long-term care residents died of COVID-19. Next slide, please. As far as we know, the province does not systematically report COVID-19 case counts for deaths in other types of settings, such as group homes, detention centers, or shelters, but through different types of data and sources, we know that the situation has not been good. Next slide, please. We can move rapidly through this next set because they're just examples. This is a wonderful article, again, by Nora Loretto and McLean's, about what happened to adult group homes near the beginning of the pandemic. It's a very, very upsetting. Yes, for sure, this is all an undercount, right? Which is so disturbing. Anyway, you can just see that in group homes, in shelters, you'll see on the next slide, in prisons, the situation has been very bad, and I don't know that we have good data to demonstrate how bad it is. So this is the last mutual fact that we want to establish before we get into our actual data. The health and safety measures recommended to congregate settings have particular implications for health equity in Ontario. Next slide, please. So this is a slide I'm actually going to take a minute and let everybody read because we spent a long time crafting this as a group when we wrote a paper about the data you're about to see. But one thing I want to emphasize is that I don't know what it's like in your profession, but when you work in public health, you're constantly being urged to talk about vulnerable groups and completely disappearing the systems that are actually generating vulnerability. So we just wanted to be very clear here that vulnerability is generated by the state and by colonization and white supremacy and ableism, and that is very much at work in terms of who is compelled into these facilities that you will hear have been not just neglected by public health, but particularly neglected by public health. So we're just going to give people 2 minutes. And I know that there's many people who are not just aware of this, who are more than aware of this context. And we know not everyone needs to hear this, but we just want to make sure that it's there for those who do. So we're just going to give you 1 minute to read it. Okay. I hope everybody's had a chance to give this a read. And I think what we really want to emphasize here is that in the context of this dynamic, as it says on the last line of the slide, the health and safety measures prescribed for congregate settings have particular implications for health equity in Ontario. So we hear a lot of talk from PHO, from Toronto Public Health, about all these institutions about health equity, but a lot of the quote unquote vulnerability that they talk about, they are generating themselves, and we're going to see that. Now we're going to actually get to our data. I'm really interested to hear more about this BC data when we get to the question and answer part. Okay, next slide, please. This is some citations for the slide before. This is also in our paper, just demonstrating, you know, all the things that we said. And of course, there are endless citations that we could have chosen for this, but these are some very good ones. Next slide, please. So back to our research question. So we all now agree, I hope, that by January 2021, it is known that COVID is transmitted through the air. Transmission can be mitigated by indoor air quality measures like ventilation and filtration. Congregate settings put workers and residents at high risk of infection. So now we have the question, in 2021, did public health guidance in Ontario designed for congregate settings reflect evidence of the above? Drum roll, please. Next slide. So it's a really simple answer. No, it did not. And we'll tell you how we got there, but we just really want you to sit on this stark no for a moment, because we're talking about October 2021 in the middle of the pandemic. And as you'll hear, none of that changed for many months to come. Okay, next slide, please. We'll tell you how we reached this information. So we started off by looking at, we knew that Toronto Public Health was responsible. We were particularly concerned about shelters. We thought, where will they be getting their public health information? They'll be getting it from Toronto Public Health. So what is Toronto Public Health telling shelters? So we looked through this congregate living setting resources toolkit, which had about 25 different resources. And we looked at all the resources and we searched for ventilation, filtration, portable air filtration, HVAC systems, even windows. And we found almost nothing. And I'd just like to mention that the last time we checked, this was still live on Toronto Public Health's website. Even though we've contacted them numerous times about it, they've actually come to presentations that we've given about it, but we're having a lot of trouble driving any change. Toronto Public Health did add a ventilation section to their homelessness and COVID-19 page, somewhat after we released a rapid review about our findings. If you can go to the next slide, please. So yeah, these were our findings, but the second finding that we found was that most of the materials cited there were sourced from Public Health Ontario. And most of those contained absolutely no references to airborne transmission. So we thought that Public Health Ontario would probably be our next stop for auditing their guidance. And the other thing that we found, I'm not sure if we have it on the next slide or not, but was that a lot of local public health units were using Public Health Ontario's guidance. So this had provincial-wide ramifications. So we wrote a rapid review based on that, which is available on the MAP website, which is there, and we did share that with Toronto Public Health. Next slide, please. Then we decided to look at Public Health Ontario's guidance in a very systematic way. So on their website, Public Health Ontario has a page for COVID-19 guidance for congregate settings and a page for COVID-19 guidance for long-term care homes. The way that Public Health Ontario defines congregate settings, it's shelters, group homes, in some cases correctional facilities, supportive housing. I think that's about the gamut. And then they have separate but linked information for long-term care homes and sometimes retirement homes. So we looked at all the guidance that was available on their website and that was specifically for some of these settings and that had to do with COVID-19. And we found 11 different guidance documents for our sample. And we audited each and every one for, again, HVAC, ventilation, filtration, windows, the word airborne outside of the context of airborne aerosol generating medical procedures. And we found not one mentioned any of their resources. The reason that we're highlighting this resource here, planning for respiratory virus outbreaks in congregate living settings, it is from our sample. It's still live on the PHO website, and it still doesn't mention ventilation, filtration, or anything like that. So next slide, please. So again, this was our main finding. And what we want to talk about now is that this remained the case until June 2022, because we kept sort of auditing the guidance. There's still old guidance up there, but they did add very brief mentions of ventilation and filtration to some of the guidance for congregate settings and long-term care homes in June and July 2022. Next slide, please. One thing we did find that was sort of shocking was that while PHO's checklist for long-term care homes and congregate settings did not include indoor air quality measures, their checklist during the same period for summer camps, schools, and clinical offices did include references to HVAC and ventilation. These were lousy and incomplete, but they were there. So that, it doesn't just suggest, it demonstrates that PHO was offering better guidance to one group of people than it was to another, which is very disturbing. Okay, next slide, please. So this is what was emphasized, and this will surprise nobody in this audience, but this was, we sort of did a kind of analysis of what was emphasized throughout all the different guidance documents, and you'll see the sort of suite of measures that we're all very familiar with at this point. Next slide, please. So this study is now, it was published as a preprint, but it's now under review. And there's also plain language at a journal, and then there's also a plain language summary of our findings available here. We did obviously share these findings with PHO many times, starting in September 2021. But as we said, you know, there were no changes, and the changes that were made were very small and not announced widely as far as we know. And those were made in 2022, summer of 2022. Next slide, please. So we decided, since we weren't getting any traction with PHO or really with Toronto Public Health, we were going to start creating our own resources. So we started creating some plain language resources, and we also set up these indoor air quality consultations for community spaces and congregate settings, which we've been running for about a year. So what happens is a community agency, a shelter, we've seen a lot of drop-ins, a community health center, comes to a virtual consultation with Amy and Jeff and me, and ask whatever they want about their specific facility. And then we write them a letter that they often use with their funders, with their landlords, or with their facility managers to try and get done the changes they need to get done. One of the big obstacles people are facing is we often hear they know what they need to do. They might need some detail from us, but they ask us for quote unquote official public health guidance to compel the people that they need to convince. So the absence of thorough and appropriate guidance for these settings has had a real material effect. But these consultations have been amazing, and we've learned so much from them, and they really informed our next steps and continue to. Next slide, please. Which brings us to the checklist. And I'm now going to hand it over to Amy Lee. And thank you so much for listening.
Well, thank you, Amy K, for providing kind of the context and history of the overall process and the journey we have walked through in the past 2 years. It is still frustrating and upsetting for me every time listening to like all the process we have been going through. But at the same time, I'm very excited to share this checklist with you. And I want to start by talking about the design process of it. So as we were talking about the findings from our reviews, especially the lack of guidance on ventilation or filtration or anything related to air quality, and of course, at the same time, hearing the feedback from all the different consultation sessions, our research partners, Pat and Lana, they suggested the idea of developing a comprehensive plain language checklist ourselves for the community spaces. So Amy K, Jeffrey Siegel, and I, we formed a team. Both Jeff and I have been working a lot on research related to indoor air quality, and Amy K has been a knowledge translation specialist working with and for the communities for a decade. So that's how we formed a team to work on this project together. Next slide, please. So as Amy K already mentioned in the conversation today, this content has been very much informed by our our conversations with the community partners over the past year. And after we have created the initial draft, we also ran it past 2 engineers for review, along with lay readers, including people who are very familiar with the community spaces. And we got great input from all these reviewers, and it's reflected in the checklist. So here I would just like to thank them again for their amazing contribution, and also this is very generous. We won't be able to make this checklist available without their help. We would also like to thank our amazing graphic designer, Noah Nanton, for working with us to make sure this document is accessible. I think we'll need to always hear comments and feedback from you so that we can improve this checklist. So we would love to hear any input you may have from the session today, or when you're looking at the checklist, just let us know if you have any questions. Now, please go to the next slide. Oh, sorry, actually, you're already on the next slide. Could you go back one slide? So now with the content slide, I would like to talk more about the content of the checklist. Here is showing kind of the table of content. And with today's presentation, we hope to get you more familiar with the basic categories and the actions in the checklist, and also encourage you to share it with others. We welcome all organizations, universities, and public health authorities to use this as a teaching tool and hopefully house it on your website. And of course, like I've mentioned, if you have any questions or comments, please feel free to let us know. We will revise it periodically and make sure you always get the most up-to-date version if you share your email address with us. So from this table of content, you can see, in addition to the introduction, there is chapter 4, which has a longer list of content focused specifically. Thank you so much, Kevin, for zooming in. Focused specifically on the different sections. And I will go through some of them with more details in the following slides. But before that, I would just want to highlight some of the key components of Chapter 4. So as you can see here from the checklist, the first thing we focused on is the centralized HVAC system. And especially in the checklist, we talked about how and if your HVAC system is bringing you clean air. This is worth mentioning because even your HVAC system is running or even running continuously, it does not necessarily mean that this is always bringing the fresh outdoor air or the well-filtered indoor air. And for this reason, in the checklist, we shared key questions you can ask your building manager or HVAC contractor. And of course, because not all buildings have a centralized HVAC system, or even when some of them have, it may not provide adequate level of ventilation and filtration. The next thing we talk about, the portable air filters, the portable air cleaners with high efficiency filters. And we also talk about when and how to use them in different settings. After that, we talked about the bathrooms. This is a rarely discussed topic in most of the guidance, but at the same time, it is very important. And then after that, you can see we also talked about the use of the upper room and induct UV disinfection and some of the additional, at the same time, very important indoor air quality measures. This includes protocols like you need to clear the air in between the groups and also kind of maximize the ventilation through both the centralized HVAC system and portable air cleaners when you have higher occupancy level. We also talk about how to identify higher risk spaces. I'll come back to this topic later in the presentation. And of course, we need to talk about masking because this is one of the most important strategies to reduce the transmission of COVID-19. And finally, there is a section on how to avoid and address some of the common problems that may come up during the process when you're improving the indoor air quality. Next slide, please. So the next thing I want to talk about is this best practices checklist in Chapter 2. When we were developing the format of the checklist, we actually had PHO's checklist in mind because we hope this document could coordinate some action. So we use this best practice checklist to provide a quick overview of the practices you want to have in place to improve indoor air quality and, of course, create a safe environment for everyone. The core information we would like to share with everyone, including facility managers, IPAC lead, public health inspector, and also public health professionals, is that these are some of the most important items you should pay attention to. From our experience talking with community organizations, we find that many people already have some of the information from their own research, but we thought it would be very helpful if we have a complete list of action items and also to clarify some questions people may have. So here is just a high-level summary of the best practices. In the checklist, we also provide more details on how to achieve every single point in the checklist. Next slide, please. I also want to now talk about the first section of our checklist, which is focused on the centralized HVAC system. When we're designing this guide, we tried to make sure that we're explaining things in a way that can be applied to how infection prevention and control work in real world in community spaces. For example, we learned from talking to community organizations that many of them do not own the space. So they often need to negotiate with the landlord. They do not have enough detailed information and they do not have access to the HVAC system. And even if the organization owns the space, the worker in charge of IPAC may not have the opportunity to receive the training they would need to talk to an HVAC contractor. And in addition, there are many workers not getting enough information from their employers. So based on all this feedback and to address these challenges, we organized this HVAC system section, as you can see here, as a series of questions that you can communicate directly, or maybe with your employer, or an organization can ask their landlord or HVAC contractor, so that you can initiate the conversation with some questions, and hopefully some more actions will be generated after the conversation. This also, I guess, by talking about this section here, it also gives you a window about what this checklist looks like throughout the document. Next slide, please. So as I have mentioned earlier when I was talking about the table of contents, there is also a section in chapter 4 that's specifically focused on the higher risk spaces and activities. This is because from our conversations with the community organizations, we have learned that it is not always obvious which spaces poses a higher risk. Amy already mentioned this point, but I would just like to make it very clear. It is not the people who are high risk. It is always the space and the activities, and mostly due to lack of infrastructure. What we can do and we must do is to improve the indoor air quality and therefore reduce the risk in these spaces once they are identified. That's why we believe this section is very important, since we need to identify the spaces with high risks and then provide necessary resources to address the risk. So without the mask mandate in most spaces, you know that many public spaces have relatively high risk. So of course, our first recommendation is always to wear high quality, well-fitted respirators like N95 or KN95 whenever possible. And once we have emphasized on this point, we also talk about how some of the other factors, like the number of people in the space, the duration they are together, the size of the room, and also the activities that could influence the risk. I also want to mention that this idea is suggested by someone who reviewed the document and who works in community spaces, and we're really grateful for this suggestion. Next slide, please. So at the beginning of this checklist, there is also a chapter providing both the context and definitions of the different terms. You can see how COVID spread in the air, ventilation. We also did the separation between the natural ventilation versus mechanical ventilation. This is because we realized that many people have been forced to jump right into the middle of the conversation about indoor air quality when the stakes are very high. But at the same time, they didn't have the opportunity or the resources to learn more about the principles and definitions of ventilation, filtration, or airborne disease transmission. And as I have mentioned at the very beginning of today's conversation, sometimes we understand these concepts could be very confusing. So this is why we decided to provide the context and definitions as at the very beginning of this checklist. We hope that by sharing this information, it could provide a little bit more support for people to navigate the questions and challenges. Next slide, please. So finally, there is another very important section focuses on the communication with people in the space. We would like to emphasize that it is very important to improve the indoor air quality in the space. But at the same time, it is extremely important to also be transparent about the process because this is a space that's being shared and used by everyone. So for example, if you decide to use a portable air cleaner with high efficiency filter in the space, clearly communicate with everyone why it is important to have this device here and what's the benefit of it. And at the same time, also consider what could be the potential impact of this device on the people. For example, one common concern of the portable air filters are the noise level. So if you put one in the sleeping area, make sure it's not causing disturbance, or at least start the conversation by talking about why it is important and also hear people's feedback and comments related to it. Next slide, please. So overall, I want to share that our team are very proud of this checklist because we have received so many input and guidance from people who have been and are still working in the community spaces. And we hope that by using this checklist, people can keep themselves and also others safe in the community space. And I really appreciate this opportunity to be here to share the checklist with you today. And we hope that you could use this checklist as well. Although for most of the context is focused on community settings, I think we believe that some of the general guidance on the HVAC system or on the use of portable air filters, even the exhaust fan in the bathroom could be applied into other settings like the common workplaces or in some of the residential settings. I'm not sure if there's any public health authorities here today, but if you're also joining the session today, again, we would love to work with you to honor and support people who have been working so hard in community spaces to keep themselves and everyone around them safe. Now, at the end of this presentation, next slide, please, sorry. At the end of this presentation, we would like to share the important next steps that we have shared more than once before, but we just want to re-emphasize the importance of the next steps in general for public health. It is so important to address the problems and issues related to indoor air quality, and especially to update the current guidance and information on indoor air quality. Well, we have shared a lot of information like the reviews, like the different articles, this checklist about indoor air quality, and we will continue to do it for sure. But at the same time, it is not enough or systematic with the facilities and workers. So we hope that the public health authorities could also take action and share the information, both the updated document and also any changes that has been made in the document directly with facilities and workers. So today I would like to take this opportunity again to ask public health authorities to take this up, because from what we have learned from the hundreds of conversations over the past year, through both our online consultations and also through phone calls and webinars, this information and guidance are much needed by the community, and there are lives at stake. Next slide, please. So now with the final slide, I just want to mention this is the web page that is housing the checklist right now. There are also information about our 2023 office hour flyer and some of the other plain language resources we have created. And now I would like to conclude this presentation and answer any questions you may have. Thank you so much for listening.
Thank you so much, Amy and Amy. This work is phenomenal. Like, it is just so important. We really appreciate you sharing with us. And I know, Amy Katz, you say you have a hard stop at 2. And look, we've got 13 minutes for questions. And this kind of really joins, like, if we look at the information shared by OPS, the professional engineers in Ontario group, and there's some leading guidance material that's being provided by you. Now, I haven't had a chance to look at the chat box. I will, but I just thought I'd lead the first question anyway. I'm thinking about the audience. We have kind of a diverse audience here, and you know, there's a lot of workers that will be working in community settings, and I'm just thinking about who do you think the audience for this guidance material are, like in general terms? I have an idea, but I'll share that after I hear from you too.
I mean, I can start, and I have an idea for the second half of that question, but we really want it to be people who are working on the ground in settings where they're trying, like workers who are trying to make their workplaces safer, employers who are trying to make the workplaces safer. And we're really focused on the kind of community spaces we've been consulting with. So drop-ins, food banks, shelters. We hope that long-term care homes use this as well. We find that in particular, we're dealing with a lot of not-for-profit organizations versus, say, city or provincial run organizations. I'm not sure why. I think there's a lot of knowledge translation mapping to be done about where people are getting their information and where those gaps are. We have a question in the chat that kind of speaks directly to your question about vehicles. Do you see this, Amy? Around, somebody asked, they work in a community setting with stakeholders who transport COVID positive persons in vans and similar personal vehicles. They often have plexiglass barriers, but transport many people over the course of the day with no consideration of aerosols in the back passenger area. And the reason I raise that in answer to your question, Kevin, is because that's exactly the kind of question we get in our office hours. And that although we don't address vehicles at all, but I'm hoping Amy can take this question, but it's people like that who are working with practical everyday questions, have concerns about worker safety or patient safety or resident safety that public health is not helping them to address. That's who we hope is our audience. Does that answer your question?
It does, and I was just thinking, I don't know if you had a response to Dr. Lee to that. Did you have anything to add to that?
Well, I think Amy K did an amazing summary about the audience we're hoping to reach. I didn't see the vehicle question, by the way, in the chat. I think it was a more specific question, but I see there is another question in the chat related to what about the schools? So currently in this checklist, it's really focused on community spaces and congregate settings. So we are not talking about schools. And one of the reasons is because the buildings are often very different in the different spaces. And we were hoping to create a guidance that's as specific and as helpful as possible. The other reason is when we were doing the initial review of documents and guidance from PHO, like Amy has mentioned, we found that there was some guidance related to schools, although they were not up to a high standard or very helpful at all. But it is the community spaces and congregate settings that has been ignored for the longest time. That's why we also decided to start from there.
Amy, do you have an answer to that vehicle question? Like how people can keep themselves safe? Let's say you're in a van and you're picking somebody up from a hospital and driving them. Is that something we feel like we can answer beyond, or is that outside of the scope of our work?
Well, I think I can talk from the general protection perspective. So I want to state and also make it very clear. Sorry, I think I'm also hearing some feedback. Are you also hearing feedback?
No, you sound fine.
Okay,
Yeah,
great.
the quality's great. The sound quality's really good from my end.
Oh, great. Thank you for the confirmation. So the point I want to make very clear is there is not a perfect strategy that's going to just eliminate the virus and make sure there is no transmission at all. What we can do is to use the different layers of protections, the different strategies to work together to reduce the risk of transmission. This is kind of the famous Swiss cheese model many of you may have seen in the past. So as a result, in terms of the layer of protection in the vehicle, the first one would be absolutely to wear well-fitted high quality respirators like N95. And the other thing to do is for most of the vehicles, because there is very limited filtration, we don't even know about what's the quality of the filter most of the time. Keep the vehicle windows open as long as weather and also safety permits. This is going to increase the ventilation in the space and also reduce the risk. I think this would be the most applicable approach for most of the vehicles, especially if we're just talking about private vehicles or maybe some buses or vans, wear mask and also try to maximize the ventilation through the natural ventilation by opening windows. Because once you have the car driving, the vehicle moving, then there will be air coming from outside. Kevin, I think you're muted.
Okay. Thank you very much. I know I saw something tweeted quite a while ago that if you have your vehicle set on recirculation mode, the air conditioning system, and there's a number of people in, you're breathing other people's air through the recirc rather than having air come in, which was quite interesting. And you know, it's always handy to carry a carbon dioxide monitor around with you too. You can kind of open the windows and you can show the driver the reduction in CO2 that kind of makes the air quality better as well. And I guess the other thing I just wanted to throw out there in response to the first question, this, even though it's for community settings, you know, workers working community settings, this would be pretty fabulous for joint health and safety committees, for example, to table and talk to it and follow up on it and then talk to, you know, their employers. So yeah, that was what I was thinking also when I was kind of leading into that question. I can't see any other questions in the chat box. I don't know if anybody else had any questions. You can raise your hand, whether you have any questions, Val or Krista.
So sorry.
Go ahead, Amy.
Oh, there's just a couple of interesting questions that I don't know the answer to, but maybe Amy Lee does. What are your thoughts about building indoor air quality certifications for buildings that we are seeing in the GTA? Well building standard EACH scores for building spaces? I have some thoughts about that, but Amy, I think yours are more important on this topic.
Well, in general, I think this is a great approach and direction moving forward. I think the COVID-19 pandemic could be used as the call for action for us to take steps to address indoor air quality related issues in general. And this is not only just to reduce the transmission of infectious disease, this is also just for the health and well-being of building occupants in general. When talking about monitoring specifically, I do want to share my concerns. First of all, it is very important that we have monitors of the indoor space, but at the same time, the parameters we're monitoring, for example, carbon dioxide, and the location of the monitor, if it's placed in a well-mixed environment, or maybe it's too close to some of the individuals, because carbon dioxide is emitted from people, and how to interpret the result, how to share this information with others to make sure you have effective communication, and to make sure that the occupants inside, when they see the numbers are too high, they know how to take action, or at least who to call. These are all very important factors to consider. But in general, I do think this is a great direction moving forward. It's just at the same time, we also need to consider the different factors. Amy, you're muted.
John Udig
Sorry.
is an occupational hygienist in OHCOW, has a ventilation calculator. And the whole idea behind that was to use the calculator to figure out the air changes per hour, and then put a form on even on the outside of the door to let everybody else know that, you know, the office or the environment is kind of safe. So, you know, I think that's the way forward. You know, having these safer spaces.
Well, I think in general, having a calculator, again, is a very helpful tool. But at the same time, you still need to consider the same factors that may influence the concentration, because the indoor concentration, no matter if it's for carbon dioxide or for some of the other pollutant, is not going to stay constant. It will be influenced by, for example, the airflow rate, maybe the pressurization of the space, the wind condition, weather condition, and the number of occupants inside and the activities. So it is always important to pay attention to these details, while at the same time monitoring what's the overall trend of the carbon dioxide, so that we can have a better understanding of the indoor space. But having the monitors there and also have the calculators as very helpful tools is a great first step.
I also just wanted to share an answer to that question. Some of the organizations we consult with are so under-resourced, they don't even have HVAC systems, let alone, you know, resources to do, you know, to meet some kind of certification. So I think it's really important. But I also think somehow, and I don't have the answer to this, those just getting current organizations up to any kind of standard, because right now we're almost asking people to throw things at the wall. Open windows if you can, add as many portable air filters if you can. We're also finding that, you know, it can be difficult for people to find trusted people to go in there and do different kinds of tests, because some people are selling products and other things like that. So finding people, even recommending what their next steps are, can be really difficult. So, and the last thing we would want to do is put anybody like out of business or have to close their building, because a lot of them are doing really essential work. So we're always kind of balancing that as well.
Thanks so much. So we're kind of like, it's 1:59 at the moment, and I just wanted to let everybody know, and you might add to this too. I see there has been consultation provided. So when I went to the website, people can actually go and they can have a consultation period. And, you know, this information is so fabulous, and there's been so much work put into it. Does that still happen? Can people still consult with somebody through MAP, and how do they do that? I think you're muted, Amy.
Always muted. Diane, I can see that's a really good question in the chat. You can come to our office hours. You can email us also directly for that, because I know we're not going to have time to cover that. If you go to that page, maphealth.ca/ventilation, you'll see our office hours for 2023. So yes, and also the question about migrant farm worker spaces. I don't know, Amy, if we can take that on, but I'm also going to put my email address in the chat. So I'm not the one who can answer these questions, but I can pass you on to either Amy or Jeff. But yes, we have, those consultations are ongoing. And these questions are so important.
Okay, so evidence-based knowledge, action, translation in real time. It's wonderful to see. And I think we've kind of come to a close from the first session. It's just 2:01, and I think we need to move on to the next speaker. So I really, really appreciate both of you sharing this fabulous work with us. And thank you. Thank you so much.
I'm not actually sure that Ryan's here yet, so we could if I guess Amy Katz, you have to go, but Amy
I've got like maybe 3 more minutes, and I see this. Where is it written that if businesses can't afford to fix it, workers? I mean, I'm not suggesting that at all. I guess sometimes we're just thinking like some of these are drop-ins where people are coming in from the cold and they have nowhere else to go, and it's sort of like a busted church where they're opening windows, but that's an excellent point, and no worker should ever be put at risk. But that's the kind of thing I was balancing in my head. But I appreciate that comment, and I think it's an excellent point.
There's also a question here from Monona Russell to everyone. If there is an HVAC system, it usually was designed and installed to the standards in ASHRAE 61.2. In this case, the occupant should ask for the more recent balancing report. If it is done by a certified balancing company, it should have the air changes for every room documented. We often demand such a balancing report in my union. So I think just on that point, getting an indoor air quality assessment, having a balancing report to talk about the air changes per hour is really important. Did you have any thoughts about that, Amy Lee?
Well, I think if this kind of information is available and you're asking the right question, it is great to request for any reports on the HVAC systems. This is not only a way to understand the building better and understand kind of the relative risk. It is also a great way to pressure sometimes the landlord or employer to pay more attention to the building infrastructure. But I do want to mention that the ASHRAE 62.1 needs to be updated. It is currently mostly designed to provide the minimum ventilation, and we all know that depending on the situation, this may not be very effective for infection control. But the other thing I want to mention, and this is from the context of working with community organizations, is for many of the cases, they do not have a centralized HVAC system at all to start with. And there were also times they do not have operable windows. So when this is the situation, then you know that instead of just monitoring or maybe asking for indoor air quality assessment, and especially if there is very limited resources, then maybe it's more important to invest directly into portable air filters, because you know that the current ventilation or filtration will not be adequate. And given the very limited resource, I would always prefer to spend the money into the mitigation strategies instead of doing the air quality check.
You can measure and measure and measure, but really what we want to home in on is providing the controls as soon as we possibly can to reduce transmission. It's a really good point. So I think there's probably a few other questions in the chat box. And it's really good that Diane Wallace is here. Like Diane Wallace works with the Red Cross, and we've spoken about that issue, and it'd be really good if you could follow up with Diane on a question, and we'll continue to work with Diane as well about that. So thanks for joining, Diane. Great.
Okay, great. I see Ryan, you're here. That's great. We're wrapping up our first conversation to
no problem.
Into the next one, talking about ventilation in all kinds of buildings.
It looks like Amy Katz is gone, but I just want to thank you again, Dr. Amy Lee, for giving such a great talk and presentation. So then over to you two, Val and Ryan. Thank you.
Okay. Thanks, Kevin, and thanks so much, Amy. We really appreciate all your efforts today, but also in building the checklist and especially in answering people's questions with those call-in availability. I think that OHCOW too offers an inquiry service that people can call us with their questions and challenges, but it's great that you are doing that specifically for air quality. So thanks again, Amy. So now I'd like to welcome Dr. Ryan Gregory, who's going to spend the next hour with us talking about viral evolution. We're all, well, I have to say I'm a follower and love the curation of current articles and the snide remarks, or not snide, the perceptive remarks, I would say, about headlines around the world. And how they so often misrepresent things, or else how the science is showing us that we're still dealing with a really serious problem. And that's our efforts here at OHCOW all along with these sessions, is to try and bring the science and talk about its implications for workplaces. And mostly all of us try to talk about what we can do to make a difference and improve things. And at least we thought we were preventing the pandemic. We're now well into it. We want to slow things down and hopefully eventually reverse course. Thanks again for joining us. I don't know if you want to try and share your slides while I read your bio.
Okay.
So we're going to talk about what's new in the evolution of SARS-CoV-2. And this is Dr. Ryan Gregory from the Department of Integrative Biology at the University of Guelph. He completed his BSc in biology at McMaster and his PhD in evolutionary biology and zoology at the University of Guelph, after which he carried out postdoctoral research at the American Museum of Natural History in New York and the Natural History Museum in London, England, before returning to join the faculty at the University of Guelph. His academic interests include genome size and junk DNA, biodiversity, evolutionary theory, evolution education, and scientific communication. He has been the recipient of research awards from the Natural Sciences and Engineering Research Council of Canada, the American Society of Naturalists, the Canadian Society of Zoologists, and the Genetic Society of Canada, as well as a teaching award from the University of Guelph. From 2018 to 2022, he was chair of the Department of Integrative Biology, and from 2014 to 2021, he was editor-in-chief of the journal Evolution, Education and Outreach. So we really appreciate you joining us today to practice your scientific communication, and look forward to the presentation and the discussion afterwards. Thanks.
Great. I just want to make sure you can see.
Yes, we can see your slides. Yeah.
All right. Well, let's go. So I am going to try to leave quite a bit of time as much as possible for questions. That might be more effective than me just rambling on with a bunch of details about evolution, but I am going to try to give some background, and then I will open it up to whatever kind of conversation people would like to have. So I want to start, you mentioned that the importance, or what I see as the importance of scientific communication and framing of information. I think if we look at the way that the virus has been described since really early in the pandemic, you can see examples where decisions on how to communicate information have had significant impacts on people's perception. Sometimes that's by design, but I think it can also have unintentional consequences. So if you look at what the World Health Organization suggested in February of 2020, so very early in the pandemic, was to refer not to SARS-CoV-2 or SARS coronavirus 2, but rather the virus responsible for COVID-19, or the COVID-19 virus. And the reason they did this was specifically to avoid stigmatization of places that suffered most or disproportionately from the first SARS outbreak in 2003, and mainly Asian countries, but also in Canada, of course. And to, in their words here, essentially avoid creating unnecessary fear. So I think it's worth noting that this week, the World Health Organization released a revised estimate on the number of deaths, or the overall excess mortality as a result of the pandemic, and we're now essentially acknowledging around 15 million global deaths. So whether, avoiding unnecessary fear should have been a priority early on, or actually conveying the seriousness of the issue, I think the point is that what we call something and the way we communicate about it is important in framing how people respond to it and perceive the risks and the issues. And there's a bunch of other sort of words that you're going to hear through this that I think have similar effects. So I want to talk a little bit about the nomenclature system that gets used for different variants, particularly different variants within the Omicron group, because I'm going to be referring to these a fair bit. The names that you're hearing a lot about, the so-called alphabet soup, things like BA1, BA275, BQ11, those kinds of labels, those are based on a resource that's called the Phylogenetic Assignment of Named Global Outbreak, or PANGO resource, and these are PANGO lineages. And the way those names are given is basically they just follow in sequence through an alphabetical order. First A's, then B's, and then once they've gone through the entire alphabet, A all the way through again, then AB all the way through again. And we're now, talking about BQ and so on. So there's been a lot of variants. Let's just put it that way. That's followed by a numerical suffix, which indicates the first one, which of the variants within that designation it is. So if it's the first descendant, it would be BA1, for example. The second descendant would be BA2, and so on. And additional descendants of those can be indicated with a third decimal place. So for example, BA275 is the 75th direct descendant of BA2 that was identified, and BA2 is the second BA that was identified. So that tells, in terms of technical terms, it tells you that BA275, that's a pretty big group with at least 75 different descendants associated with it. But in order for this not to get out of hand, because there's always, variants begetting other variants, there's a maximum depth of 3 layers of decimal places under this naming system. And then it rolls over to a new prefix. So for example, BQ11 is technically B1152953111111. But that gets even more unwieldy. And so we have the names roll over to BQ1 and then BQ11. And if you see a name that starts with an X, that means it's a recombinant variant. It means it's 2 variants that have basically hybridized to form a new variant. So those are the sorts of the names that I'm going to be talking about. The other names that you'll be familiar with are the Greek letters. So Omicron is the current dominant one within this naming system. So in May of 2021, it was, I think, realized by the World Health Organization that what we were likely to see was waves caused by things that weren't the same as the original virus that spread around the world initially, or what we call the wild type, that there were these new variants that were going to be either causing waves or have the potential to do so. And so we needed to track them and keep an eye on them. So they introduced this Greek letter naming system. And have used it to name a bunch of different variants. And they had 2 categories: variants of interest and variants of concern. Variants of concern sort of a increased level in that they are actually increasing over time, or they seem like they might have features that would make them especially dangerous for populations. So the ones you're most familiar with would be things like Alpha, Delta, Omicron, ones that cause significant waves in Canada and elsewhere. But there were others, and there were also a large number of variants of interest. Now, I'll just point out, they skipped a couple of letters, that the most recent and the last one that was given was a year ago, was Omicron. They have not given any more Greek names to any variant since Omicron in late 2021. They do, however, have a new category that they call Omicron subvariants under monitoring. They're really only subvariants in the sense that they aren't called new variants. They just keep getting called Omicron. So to put that in context, this is an evolutionary tree, or what we call a phylogeny. It basically shows, it's like a pedigree or a family tree. It's showing series of relationships and ancestor and descendant relationships. And what I've done here is just label the different named variants, the ones that got names and showed up in large enough numbers to be included in this figure. And in many cases, you can see that things like kappa and beta and iota and epsilon were present in fairly small amounts. They were pretty genetically similar to each other. They didn't, take off and evolve into a whole bunch of new descendants. They essentially fizzled out, but they got Greek names. And as I said, with Omicron, all of the evolution that's occurred in the past year is represented here, and it's still called Omicron. So this is another example, I think, where what we call things or don't call things can have impacts. And in fact, you will sometimes hear this question about, isn't it all just Omicron now? Well, it is, yes, because they don't give Greek names now, it seems like. But we'll talk about what's different about Omicron versus these other variants. But just looking at this evolutionary tree, you can see that there's a lot of deep branches, distantly related things that share a common ancestor, but are genetically very different from each other, still all called Omicron. And just to point out that the scale on this is actually the number of mutations. So the farther along it goes, the more genetically divergent it is on this axis. So to this question about, isn't it all just Omicron now? The answer is yes, in that they're all called Omicron. But no, in that I think that's very misleading as to the amount of variability that actually exists. So if you look at Omicron, not as a single variant, but rather as a large, diverse evolutionary group, you might draw an analogy between Omicron and, say, mammals. So yeah, it's true that a bat and a mouse and a human and a whale and a giraffe are all just mammals. That doesn't convey enough information about how different they are to just say mammal. So just calling everything Omicron really is talking about membership in a large group. It's not talking about the differences among them. And we do have a way of distinguishing between different members of that group, which is namely those pango lineages that I mentioned. So the rough equivalent here would be between, the formal Latin zoological names, the scientific names of species within mammals versus the pango lineages within the group of Omicron. But again, that's very helpful for technical discussions. So you can look at and say, okay, so it's in the BA2 lineage and it's the third descendant of BA2 and the 20th descendant of that one. That's useful, but it's not very easy to convey properties or information about those variants in a broader context outside of those technical discussions. And so what's kind of missing here is the equivalent that we have in naming animals, which is common names. So if something is dangerous or tasty, or we encounter it often or whatever, and we're talking about it for various reasons, we will often have a common name. So that's not the scientific name, that's the name that we usually refer to in general discussions. So for example, you may not have known what Heliarctos melianus was, but you might have heard of a sun bear, or you might have heard of black bears and brown bears and polar bears. We use those to communicate more broadly than in technical discussions. So some of us have suggested that we kind of need this, if everything's just going to be called Omicron, and the alternative of having these really specific technical names is too detailed and too hard to access, we sort of need the equivalent of common names. So informally, there have been names attached or nicknames attached to the most important or the most widely discussed variants within Omicron, using names from Greek mythology to kind of go along with the Greek letter naming system. So instead of just BA2320, you might hear Basilisk, or you might, instead of BA275, you might hear Centaurus, and so on. I think I saw something pop up about BF7, nickname for that one Minotaur, and that seems to be one that's taking off in China right now. The other thing I want to point out is that when you're talking about the evolution of a virus, it happens at two different levels. So it happens within the host's body, the individual host is infected, and it also happens among hosts in the population of the hosts. So when we talk about within host evolution, what's going on there is you will end up with kind of a swarm of slightly variable versions of that virus, all within the same individual's body. That could be because they were infected with more than one slightly variable version, or it could be because there were mutations that added some variation. But what's going on with the features that are the most fit and ones that will become the most common within a body are things like, can it replicate faster than the alternatives that are also in that body? Is it better at entering host cells? Does it attack more tissues and therefore it can make more copies? And those kinds of features being under selection can lead to more damage to the host. So if it's attacking more tissues and replicating faster and killing more cells, it can do more damage to the host, or what we would call increased virulence. And this is most likely to occur in individuals who have long-term infections, persistent infections. They stay infected for a longer period of time. And often that means somebody who's immunocompromised, for example. Then you have another level, which is among hosts. So you've got the entire, say, human population. In that case, it also matters from the virus's standpoint whether or not it's successful in getting to a new host. So from one infected host to an uninfected host and subsequently infecting that new host. That's a different set of traits that are going to confer an advantage in that situation. So it's the ability to get to another host. So for example, maybe a particular variant is present in higher abundance in the infected host. And so every time they sneeze, they're sending out way more viral particles than they would with a different variant. Maybe it hangs in the air longer, or it can survive longer outside of a host body, or whatever, those kinds of features that make it more likely to be taken up by another host. Its ability to actually infect the host that it encounters can also be a factor. So does it preferentially attack more easily accessible parts of the body? So for example, if the virus infects high up in the respiratory tract versus has to be breathed all the way down deep into the lungs, obviously the first one is potentially more likely to infect. Is it better at getting into the host cells? Those kinds of things. And increasingly what's important is, can it escape existing host immunity? So can it get into and infect a host that either already had an infection, so a reinfection, or can it get around the immunity that's conferred by vaccination? So in other words, are hosts still available to it even though they have some degree of immunity? And this is more likely to happen when you've got widespread unmitigated transmission. So you got a lot of opportunity for the virus to be moving from one host to another. It's thought that in general, those major deeply divergent, distinct, lineages that have the Greek names evolved within individual hosts. That they were probably in an immunocompromised host or somebody else with a long-term infection and evolved within that individual and then were moved back out into the larger population. So it's a reason, aside from protecting the vulnerable because it's the right thing to do, it's also suggests that it behooves us all to protect the vulnerable, those who are immunocompromised and may suffer persistent infections, because that's where these really big, divergent, problematic variants evolve. So every reason to protect the most vulnerable. There's often a notion, a common notion, that viruses will evolve to become mild, that sort of inevitably they become less dangerous over time. And that's just a myth, essentially. There is no strong tendency for viruses to evolve in that direction automatically. Virulence, that is the amount of damage that a virus does to the host, evolves more as a byproduct of other things going on. It's not usually under natural selection directly on its own. What's much more important in the way the viruses will tend to evolve, including with SARS-CoV-2, is the success it has within a host relative to the other versions that are in the host, and whether it can get to new hosts. And that may or may not come with increased damage to the host. So the idea that we can just sort of assume that each new variant is going to be less virulent or less damaging is not correct. And likewise, you hear terms like endemic. So in many ways, the discussion kind of developed such that people thought endemic meant pretty mild. So the problem is we have this pandemic, and once we get to endemic, it means that it'll be manageable and it's the impacts are not so bad. That also is a misuse of the term. Endemic essentially just means that it's present in a particular area at a fairly constant amount. It's not kind of rapidly fluctuating all the time. It's not rapidly moving across different regions. But if you go to a particular place, it's just present there. It does not mean that it is not dangerous. So things like malaria and tuberculosis and measles and other things like that can be endemic in various parts of the world. And endemic does not in any way equate to harmless. So the idea that viruses will always evolve to become milder, or that endemism means that we've kind of got to a point where it's livable, is not correct. That endemic could mean present at a very high baseline and causing a lot of problems kind of all the time. Again, things like malaria and tuberculosis are endemic in various parts of the world. I also want to revisit sort of where we were roughly this time last year. So this is a piece that was published in late November 2021, right after the sort of end of the wave caused by the Delta variant, and it was asking this question: is that the last one? Are we done? Like, are we finished with these variants now that we've had Delta? I think you probably mostly all know what happened next, and not long at all after this and then along came Omicron. So Omicron showed up sort of December of 2021. So pretty much a year we've had Omicron. But it's worth noting the same things that are sort of being said now, well, maybe Omicron's the last one, were said about Delta a year ago. It's certainly not the case that Omicron was mild. It was sort of pitched as it's going to. It seems to be mild. That was based on observations of quite a small number of patients in South Africa where it was first identified. But it became a dominant sort of claim and assumption that Omicron's mild, to the point where some people were suggesting it's good. It's going to be like a natural vaccine. Everyone will get infected, and we'll all have immunity. So maybe we want that. It's worth noting that if you look, for example, at that sort of November 2021 that I said, this is the number of confirmed deaths in Canada. And you look at where we were right after Delta, and then Omicron hit. Not only was there one of the highest peaks in deaths and hospitalizations and the rest in terms of the first Omicron wave caused by the BA.1 variant, we've had now 4 essentially waves, or 4, I'll talk whether it's a wave or not, but four periods of increased impacts due to different Omicron variants over the past year. It's the case that 2022, even in November, it was already true that 2022 was the deadliest year for the pandemic in Canada. If you look at the number of deaths and the number of days involved, sort of pre-Omicron and after Omicron, you're averaging around 46 deaths per day in Canada before Omicron, and now it's 53 deaths per day. So the idea that Omicron is mild is obviously very false. You could make the argument that per infection, so on the basis of, like, if you get infected, what are the odds that it's going to be really, really, really bad? That is probably lower, significantly lower, for a number of reasons. So either the virus has changed, and or our immunity has changed, our treatments are better, all of those reasons, that you're less likely to have a severe impact of an infection. But there are just way more infections. Omicron was really transmissible and very infectious, and as we'll see, many of the variants that have evolved are good at escaping immunity. So a lot of people were getting infected, which meant that there were a lot of people getting very sick and dying. Even if the percentage was smaller, the absolute number was higher. And that's one reason why the past year was the deadliest in Canada, and in a few other places too. So what we're seeing now is different. Omicron has changed the situation. What was the case was you would get a new variant would arise, and as I said, it usually seems like they were evolving in an immunocompromised host who had a long-term infection, and then that variant would re-enter the population and rise to dominance, become kind of the only show in town, cause a big wave, and then it would recede, and then another one would come along and replace it. So you had these really distinct, clear peaks caused primarily by one variant at a time. That was true pre-Omicron, and it was true with BA1 and BA2 within Omicron, but that's not what we're seeing now. Over the last 6 months or so, we're seeing something very different. What we're seeing now is not an individual variant that rises to dominance and causes a very clear, distinct wave. We're seeing the existence of a whole bunch of variants at the same time that are very good at escaping host immunity, that all exist at once and tend to increase in frequency and case numbers sort of at the same time. So if you look at this graph, what this is showing you is all the way back to the beginning of the pandemic. Each colored line is a single variant. So if you look at the original, Wuhan strain, or what we call the wild type that came out of China initially, the only thing around really, and then it dropped off and was replaced, by Alpha, and then that was replaced by Delta, and so on. The situation now, if you look at the far right of this graph, is there is no one variant that is all the way at the top, kind of 100% of the variant frequency, but rather a whole bunch of them existing at the same time. Those are all descended from within the BA2 and BA5 lineages of Omicron, but there's a whole bunch of them existing at the same time. And as I said, in particular, they're very good at escaping host immunity. So there is no robust hybrid immunity to Omicron. You can be reinfected, and these things specifically are evolving to be able to do that. So we don't really see these clear, really distinct peaks caused by individual variants anymore. Instead of waves, we're kind of seeing high tide. So if you look, for example, at the wastewater signal for the virus in Ontario, you'll see that these are all the Omicron waves, or the Omicron variants. BA1, the first Omicron, sort of this time last year or into early January of this year, very clear, distinct peak, did a lot of damage, as we said. Then we had another wave in the spring of BA2. Then we had what looked like it was going to be another wave, and kind of was, of BA5 in the summer. And I'll just point out that this summer of 2022 was vastly worse than any of the previous summers during the pandemic. So if you compare seasonality, the same season, vastly worse. But it never really came back down. So what we now see is the BA5 rose in the summer, and then into the fall, you had a resurgence of BA5 and some of its descendants here and in Europe and a few other places. Another bit of a decline, and now we're seeing it rising again. This time it's caused by some combination of BQ variants and hybrid variants. So whereas we had waves before, and certainly before Omicron, that was the dominant pattern, now we kind of just have a high tide. It's just not going back down. And it's not reaching those peaks, but the troughs are also not getting back to where they were. That said, we haven't had another winter yet. So that first BA1 wave was in the winter last year, starting around this time last year. So we don't know yet whether the BQs and the rest are going to do that again. But on the assumption that they're not, we still have a very high baseline now. And this is particularly worrisome if you look at hospitalizations, for example. This is in Canada again. If you look, for example, at the last sort of trough after Alpha, and then the trough, the low point after Delta, and through the different Omicron waves, there's a pretty strong increase in how high that low point is. So we often talk about how high the peaks are, but I think it's equally important to talk about how not low the troughs are, that we're just staying at a very high rate of hospitalization. In fact, the low point of the most recent BA5 and descendant kind of wave is higher than the number of hospitalizations during the other non-Omicron waves. So we have very transmissible and immune escaping variants that are kind of just around in large amounts all the time. There's some interesting things going on with Omicron evolution that's quite different from what we saw. So before, as I said, you kind of had one new variant come and it would cause a big wave, and then it would recede and kind of be gone essentially. There's not BA1 in circulation anymore. We're seeing a combination now of a lot of diversification, new species evolving. Sorry, not a new species. This is my zoologist brain talking. New variants evolving within Omicron. So a lot of diversity branching into new descendant variants. There's about 600 currently designated Omicron subvariants. with those pango names. So you can see a bunch of them here. The other thing that's happening that's interesting is, in addition to that splitting, there's what we call convergent evolution, meaning that similar features are evolving independently in different lineages. And in particular, what's evolving is collections of mutations that are being favored whenever they arise, so that you get a bunch of these independently evolving lineages that have the same suite of mutations. And those mutations specifically are favored because they confer immune escape. They're good at allowing the virus to get around previous immunity detection and removal by the immune system. It also translates to resistance to some of the treatments we use, monoclonal antibodies and so on. So we're losing some of the tools that we had that in some cases got the severity of infections down. They're no longer effective, and in fact, the FDA just removed approval for one of the treatments because it doesn't work against the BQ variant. So it's worth exploring kind of what could happen with a cloud of variants like this. This is not something we've seen before. So what could happen? Well, I think there's a few different possibilities. One is, even though you have this huge sort of diverse group of variants within Omicron, it might be that one of them actually does become dominant. It outcompetes all the rest and becomes the dominant one. That doesn't seem to be what's happening. Another possibility is that one variant becomes dominant in one place. So let's say in North America or Europe or something, and another variant becomes dominant elsewhere, maybe in Asia. And that sort of seemed to be what was happening. So in Singapore, the XBB variant took off, whereas in Europe, it was mostly the BQ group. And then the idea might be that they increase in those regions and then they swap essentially. So then XBB takes off in Europe and BQs take off in Asia, for example. Also not really what we're seeing. We're seeing is that there's movement so that several variants seem to be increasing at the same time in many places. So that's another possibility, is that you get the same subset of variants increasing everywhere. Another is that you get different subsets of variants, not just one, but a few of them. Increasing in different places, and then they swap. And then the other possibility is that we just have, it doesn't really matter who's in the cloud. There's just always a cloud, and there's a lot of turnover of membership of that cloud. So, it's BQs now, in 6 months, it'll be something else. And it's just kind of always this many variants, but they turn over. That's another possibility. So what happens next with clouds in general? Again, this is sort of the first time we've seen this in the pandemic. Well, maybe clouds will come and go in waves or in tides, high tide, low tide. Maybe all the current variants that we're seeing within this cloud will disappear, and some new cloud composed of different variants will become prominent. It could be that clouds always persist, and it's just the membership that changes. So it's kind of the ship of Theseus thing, where, if eventually you replaced every board and every part of the ship, is it the same ship? Is it the same cloud if every variant that was in it has now been replaced? I don't know. That's something of a philosophical question, I guess. But in terms of health implications, it would mean we would just always have a lot of variants out there. Or it could be that this is it. We get this cloud, this kind of happens once, and then something totally different comes along. Something that isn't even Omicron. And I'll talk about kind of how that might happen. Something that the World Health Organization would actually give a new name to, would get called pi or rho. And then there's a few questions about sort of the impacts of having this cloud of variants that we don't know yet. We're finding out. This is the first winter where we're going to have had this. And so we'll see. Can someone be infected with more than one of those variants at the same time? Co-infection is an important mechanism for generating new variants, and I'll talk about that in a second too. Can you be infected with more than one? Can you be infected with one and then short time later be infected with another one? Do they differ in the symptoms that they cause? So if you're infected with BQ1, does that give you different symptoms or different severity from XBB? We don't know. Do they all contribute equally to the risk or the nature of long COVID? So maybe they infect slightly different tissues. So one really impacts the cardiovascular system and one impacts neurological systems. That's also possible. And can you get more than one of those and have really bad long COVID with multiple systems affected? Or could you have that different subsets of the population are susceptible to different variants in the cloud? So maybe if I had Delta, I'm susceptible to XBB, but not BQ1. But if someone else had BA1, they're susceptible to BQ1 and not XBB. But that means that there's that many more people who will be infected because those variants all exist in the same population. So those are some questions we don't know. Then there's a question about, could a new major variant, something that they would call pi or rho, still evolve? And the answer to that is yes. And I can see 4 different ways that could happen. One of them is that you just get a lot of change in an Omicron lineage, and it changes in a direction that's different from this convergence that we're seeing. So it kind of evolves to be quite different, not just more immune escape, but something quite different. That's possible. There could be within host evolution of some older variant. You know, there's still Delta out there somewhere, and Alpha and Beta, and probably the wild type in somebody who's got a long-term infection. And it'll be evolving in that person. And it could be that something new will evolve and enter the population, as happened with the other variants. You can get recombination among different variants or even across different viruses, which I'll talk about in a sec. And then this other interesting concept that has been called ping pong zoonosis. Zoonosis is the movement of a pathogen from a non-human species into a human, but it can also go back from a human into a non-human and go back and forth. So this idea of sort of ping pong among species, and as it's in a non-human species, it will be evolving, you know, within the environment of their immune system, and then it can be quite different when it comes back. So let me give you this example about, you know, change within a lineage. There's examples of this with our mammal analogy. So for example, whales are very closely related, in fact, nested within what we call artiodactyls. So things like hippos and cows and deer and those kinds of things, pigs. They're very closely related to them, but they're really different biologically. And so when you look at, you wouldn't say, well, they're all mammals. Like, it matters if you're talking about a whale or, you know, a giraffe, in terms of how different they are from what the ancestor was. So we could have something similar with Omicron. You could have some one or more lineage just becomes really different. It's still Omicron, but it's so different that, you know, you really need to recognize it as something distinct. The question we might have then is there enough evolutionary potential still available for the virus to do that? Is it running out of evolutionary space? And I think the answer pretty clearly is no. I'm not going to go through kind of all the sort of technical details, but let me just point out this thing mutates a lot, and there's no shortage of genetic variation. So this analysis tried to estimate, you know, the degree to which new mutations were being added in the human host population. And I'll just point out that their conclusion was that every single possible change in one of the parts of that viral genome, every conceivable change is happening every day and being transmitted to a new host, because there's just so much of it out there. If you look at how quickly the spike mutations are evolving and accumulating in the Omicron lineage, it's really high compared to what we saw with other variants. So it's evolving very quickly as well. And then I need to point out this, you know, we may be looking at a very large new, previously mostly uninfected and modestly vaccinated population in China. So they've managed to keep the virus under control for 3 years, essentially. But now you've got what is essentially 1.4 billion previously unexposed potential hosts with limited vaccine protection. The vaccines they've used were less effective and don't block transmission in any case, you know, completely. And booster rates have been low. They're increasing, but they've been low. And so this means that what will be traits that are favored by natural selection in that population will be different from what it is in the rest of the world. And it's entirely possible that something quite different could evolve in a situation like that. It may not be able to compete outside of that population because it doesn't have the immune escape abilities that the other versions do, but that's where hybridization and recombination comes into play. We're already seeing discussions about an increasing number of these deltacron variants. So that means a delta variant that infects an individual at the same time as an Omicron variant, and they recombine and form a new hybrid version of the virus, often called a deltacron. And it's not limited to just versions of SARS-CoV-2. So it's possible that it could recombine with other coronaviruses. So there is the potential for SARS-CoV-2 to recombine with MERS, which is a very deadly version of a different coronavirus. And what you need for that is a co-infection. Someone has to have both. Is that possible? Well, there are some concerns that having the world convene in the region for the World Cup could mean an outbreak of MERS. It moves around. People also have COVID. I'm not suggesting this is a very high probability, but it is certainly possible, and that would give us something quite different from what we've seen. And then in terms of ping pong zoonosis, the SARS-CoV-2 virus is able to infect a very wide range of other species, and there are examples already where it seems like it entered humans from a bat or some other non-human, was then infected other mammals. It's infected cats, big cats, other primates, mink, and deer. And then there's the documented case of a subsequent infection from a deer to a human. So that's gone from one non-human to humans to a non-human back to humans. There's been some proposal that Omicron itself, the first Omicron, evolved in mice and then reinfected humans. I don't think that's true, but there have been proposals that could happen. So you could get this ping pong zoonosis where you get new variants evolving in another species and then hitting humans again. So what can we do? All of it comes down to mitigating transmission. Vaccination is great, get boosted, but that doesn't stop transmission, and therefore it's not really stopping the evolution of immune escape in these variants. Fewer infections overall means fewer mutations being added to the viral gene pool. It means fewer co-infections and less potential for recombination. It means fewer persistent infections in immunocompromised people where you can get major new variants evolving. And what do we mean by mitigation? Well, I think you discussed it just now. We don't mean hand washing and wiping down your shopping cart. We mean high quality respirators worn properly. We mean air filtration and ventilation. We mean reducing indoor gathering sizes or the proximity of new hosts. And I'll point out that things like masks and clean air, those are variant proof. Those are based on physics and engineering. They're not based on biology. They're not contingent on a particular variant. The spike protein doesn't matter which it is. It will get caught in an N95 mask. So that's where I think we need to go if we want to cut down on the amount of evolution that keeps happening. I would also very much appreciate it if we could stop doing this. We're now entering the 9th wave in Canada, and it seems to me that every single time we've fallen for this, yay, we made it, and then no one could have foreseen this. I'd rather not continue to do that forever, and that means taking seriously the fact that the pandemic's not done. The virus is still evolving. It's still causing a large number of infections, and we still need to deal with it. So that's sort of where I wanted to go with my background presentation, and I see we've got some time there for questions. So I'll stop sharing, and then I'll be able to see the chat as well.
Thanks a lot, Ryan. That was a great overview, and it is still quite disturbing, I guess, and I guess how can we slow it down? I think that we have been arguing week after week or month after month for airborne precautions, but so much of it is the public narrative, shall we say, even the public health narrative. But maybe there's some questions in the chat. I think. Yeah.
Did you want me to just kind of run through, or did you want to pick some? Or
I was going to ask. So Kevin asked about the BF7. I was going to ask if you've seen anything. I know I've seen some references. I've seen some references to maybe that's being inflated by Western media to make it seem like it's bad, but I'm just wondering if you've seen anything, if it's real.
It's real. I mean, BF7. I mean, these are all. There's like I said, there's 600 variants within Omicron, and some of them have been sort of identified as worth watching enough to get a nickname. BF7 got the nickname Minotaur. It's not that new. I mean, it's been around. I think the reason it's being discussed more is it seems to be increasing in frequency in China. So it's of interest there. It's quite good at escaping immunity, but they all kind of are, right? Like, so any ones that you see, and here's a rule of thumb, I suppose. Any variants that you're hearing about a fair bit are good at escaping immunity. That's why you're hearing about them, because they're around. The ones that were not good at it are gone. So BF7, it's not the predominant lineage here or in parts of Europe. The waves that we saw in the summer were caused by BA5, and then there was a resurgence of BA5 plus a bunch of its descendants in the fall. Now it's the BQs and the some of the hybrid variants that seem to be taking off, primarily in North America, parts of Europe, and so on. So BF7, I don't know that there's anything particularly notable beyond some of the other things. The one that I've seen most recently discussed is CH1, which seems to be really, really fast, like really has a major advantage over the others. It has not increased in huge numbers yet, though.
Well, it was more the BF7 in China. Is
that would be a concern? Something's going to take off in China. I think in some ways, it doesn't necessarily mean that it's got any particular features that make it more dangerous or more transmissible. It could just be the one that got there first and took off first, right? I could see that, the BQs could have got there. The thing is too that because the Chinese population has less experience with either the virus or the vaccine immunity that we have or had. I mean, booster rates are low here too. I'm not trying to say anything specific about China. That's true everywhere. But they've not had waves where, like we're talking about in Canada, BC said, something like 80% of the kids have been infected now in the last year. Like that, they haven't had that. So they are immunologically a different population. So immune escape and the kinds of things that make viruses, versions of the virus successful here aren't necessary there. Different things can evolve there. It's more going to be about, I think, about getting into new hosts and being really good at, quick transmission rather than immune escape, which is what's been evolving mostly outside of China, where they've had a lot of cases.
Right. Thanks. There's a couple comments and questions about just public health messaging in terms of the wrong phrase.
I've struggled with that question a lot, and to be honest, I sometimes think like I'm not the person who should be doing this stuff. Like I'm not a virologist or an immunologist or any of those things. I'm an evolutionary biologist, and I don't work on viruses. I work on animals and their genomes. But somebody's got to say some of these things because, the idea that it's all Omicron or the idea that this will be the last variant, like every time somebody says something like that, I go, wow, you don't know much about evolution, So why are experts? I don't know. I think, it may come down to what let me throw two things out that are fairly innocent, I guess. One is, there's a tendency to focus on what you are accustomed to, what we've seen before. So often you'll hear like, well, coronaviruses don't do that, right? In reference to the textbooks that were used in your virology course. I'm like, well, this one does. Most of them don't cause a pandemic. This one did. So, you got to be available, have available in your mind the notion that it's not the same as everything else. It's not a standard virus. So a lot of times people are wrong when they do that. They say, well, coronaviruses, don't evolve immune escape. Well, this one sure did.
Mm-hmm.
Right. So that kind of thing. The other, I think, is there's a real tendency within public health to, there's a real almost phobia of panic. That like the really most important thing is don't cause panic.
Mm-hmm.
And that ends up kind of translating to the kinds of things like, we need to not call it SARS because people will be too scared, and we got to not call it this, and we got to use, and so I think, I don't know that panic has ever been like the worst thing about a crisis. Maybe, but there's also kind of fear is a healthy response when there's a real threat. And I think it's useful to kind of be realistic about stuff. I don't go in for everything we need to panic. I'm not freaking out about MERS right now, right? I don't know how likely that is. I need to, but I'm also not saying, no, that's impossible. They don't do that, because they could do that. They could recombine or whatever. So I think it's maybe where the philosophical bent is, or the training is, or whatever. I do know that most public health experts are not trained in evolution. I mean, that's just obvious from the stuff they say, right? They get that stuff wrong. So if you have certain assumptions about how evolution works, you're going to keep being surprised by, whoa, I didn't think that would evolve. It's like, okay, but some people said it was probably gonna. Mm-hmm. So I don't want to speculate too much. Okay, so I see a thing here about immunity debt. Yeah, so I wrote co-authored a piece in the Calgary Herald about that. I've been talking about it a fair bit on Twitter. So I want to be clear. There's two different things that are being described with the term immunity debt, which, by the way, is a brand new term. That term does not appear in the scientific literature before last year. So this is not a established concept. The one is nonsense, and that is that the immune system is like a muscle, and you have to work out your immune system. And if you don't, you're going to be weakened, and you're going to be subject to more infection. I think that's sort of a twisting of the older hygiene hypothesis, which, you may remember things like, if kids don't get exposed to microbes, they're more likely to develop allergies and that sort of thing. But the hygiene hypothesis, which also is not settled science, it says let your kids play in the dirt. It doesn't say let them run around in a biohazard lab, right? It's not get infected with pathogenic viruses. It's be exposed to any kind of microbe, preferably, non-dangerous ones. So it's not true. It's just not true that you need to get infected in order to have a good immune system. It doesn't even make sense, right? Like there's that XKCD comic that kind of captures that little cartoon where someone says, well, you need to get infected and then you'll have immunity. Why do I want immunity? So you won't get right. Like it just doesn't make any sense. Like infection for health, it doesn't make sense. So that one you can dismiss, but that's still being used a bit. The other is kind of trivially true. And it's a terrible name for it, which is basically that if you have a population that has not been exposed to a virus that normally they would be, there's more susceptible hosts who don't have the immunity from that past exposure when it comes back. And it's the same reason that, if vaccine rates go down for measles, you get an outbreak, or, more nefarious things like spreading viruses intentionally to inexperienced populations with them, those kinds of things. That the two things, though, the immunity that you get comes at a price. If it's a pathogenic virus, exposing a whole bunch of kids to it doesn't come for free, that you get that immunity. And the second is, I wouldn't call it immunity debt. No one owes viruses anything, right? Most of modern medicine and sanitation and all the rest is to try to not get infected by pathogens. And so it's not a good term. It's confusing. And it's also bad because it conflates those two things. The big question, though, is even accepting the sort of trivially true version, does that account for what we're seeing? So what we're seeing right now is a huge surge in RSV, in flu. I think it's up to 15 or 16 kids in the UK have died now from strep. Massive increase in scarlet fever, which is also a strep A bacterium. In Wales, something like 35 times higher than it would normally be at this time of year. Can all of that be explained by the fact that we had lockdowns or schools were closed, 2 years ago? I think that's a hypothesis that's not been formulated clearly, has not made predictions, has not been tested empirically. It's just been accepted because it sounds plausible. But, for where we've looked, again, it's people on Twitter. It's not these health agencies when it should be. If you look at, is it true that there was no RSV for 2 years in Canada? Absolutely not true. There was a big surge in RSV last year in Canada and in Sweden and in other parts of the world. There was lots of it. So how much does it take to repay the debt, I guess, is one question. Another issue is, something like strep, which is a bacterium, you don't get long-term immunity to. You can get strep many times. So, you know, is that going to explain why there's so much of it in the UK this year? It's also not true that schools were closed for 2 years. If you look at the actual closures in Canadian provinces, Ontario was closed for like 20 weeks at that initial period, but Quebec was closed for 9 weeks. The summer holiday is 10 weeks. So would you predict that there would be less of that effect in Quebec than in Ontario, for example? Would you expect Sweden to have, you know, less of this problem now because they never closed schools and they never had mask mandates? The issue is it's not clearly articulated, it's not tested. And the other piece to that is there are alternative or additional hypotheses. So for example, on the respiratory viruses in kids, one is co-infection. So co-infection between COVID and, you know, flu, or COVID and RSV, or RSV and flu can make it worse, right? So most kids in Canada got COVID within the last year. It's all sort of since Omicron. So that's one possibility. The other is, you know, it weakens immune systems. COVID can do that short term maybe, or long term. You know, we have other examples where a viral infection makes you susceptible to other stuff. Measles can make you quite susceptible to other things. Even flu can run you down sort of for, you know, a little while. So it looks like that could be the case with COVID over the short term. And it can also potentially damage immune systems long term. We obviously know of viruses that do that. If that's true, then it's not a matter of just riding out this 1 year and get caught up and pay back the debt. It means this could get worse. And it could be not just airborne or respiratory seasonal viruses. It could be bacterial infections and fungal infections and, you know, all kinds of things that don't normally cause a big problem. If you got a bunch of immune susceptible people because of COVID infection, that, you know, and this would be the first year you would see that, because this is the year when it tore through. Omicron being super transmissible and removal of protections, this is the year it ripped through kids. So this would be the first year you'd expect to see a lot of that stuff, if those are factors. There's other sort of indirect ones, like there's a study recently that showed infection during pregnancy means that the newborn's lungs are not as developed, they're smaller. It doesn't cause respiratory problems at birth, but the authors of that paper say we need to look at whether this has implications when there's a challenge to the respiratory system, either pollution, you know, a toxin, or an infection. So if you've got a bunch of newborns that their mothers had COVID in the past year and their lungs are more susceptible, that could be possible. In terms of strep, you know, there's certain immune cells that seem to be affected by COVID, and those are involved in defending against strep and RSV. COVID can affect the tonsils, which also is important with strep. So I mean, the point is there's all these different mechanisms that might be COVID related, but there's this sort of ABC, anything but COVID approach, right? So just won't invoke those things. And so that immunity debt narrative has really taken off. And I don't know how well it stands up to scrutiny. It's certainly not true that there was no RSV last year. We had lots of it. We had a record year last year. There were hospitals that were being overwhelmed. Nothing like this year, but there were cases where the hospitals were under strain, and it was blamed on immunity debt last year. So I don't know. I mean, you know, flu was gone for 2 years. Here's the other piece to that. The mitigations we had in place absolutely crushed respiratory viruses. There was no RSV in the first year, and there was no flu for the 2 years. And then whenever I've brought up this case of Sweden, and I say, well, look, Sweden didn't have school closures. And sometimes people will say, yeah, but they voluntarily wore masks and distance. And I'm like, if that's all it took to crush those viruses, why don't we do that? So we're not even saying you need to close schools again. Mm-hmm. Right? So it's just some weird kind of thing. I will say that a lot of the people who push hard on the immunity debt narrative are the people who advocated against mitigations in kids. So they kind of have a vested interest in not, you know, it not being the case that widespread infection in kids in the last year is causing this. It would be very hard to admit that. So that's, you know, I don't want to assume motivation, but even if coincidental, it's the same group of people.
Pretty logical, I think. So Ryan, it is just after 3, 5 after. There's about 4 or 5 more questions.
Okay, I can try to do those, I think.
Okay, good. So so there was one about the rat. So the rapid test detecting the subvariants. I don't know.
Yeah.
I put in the Wikistef
So
link.
that's not so much in my area of expertise, but I will say that the frequency of false negatives seems to be higher, and they've there've been some things like updating the instructions on swab your throat, your cheek, your nostrils, and so on. But antigen tests only go so far in any case. So I guess what I would say is I wouldn't assume that a negative test and COVID symptoms means no COVID, but there's also a lot of flu and all the rest going around too.
The link I put in there shows symptoms very early, and then more than 30, like 64% positive on a rat at 5 days. So it's really important to isolate when symptoms. Because
and the guidelines on isolation don't make sense, right? Like, so the idea that you're not transmitting anymore after 5 days, I mean, that's pretty clearly not the case.
Yeah.
So
It also shows that infectiousness too.
Yeah.
And how should people be swabbing? There is a good Ontario Science Table video from last February.
Yep.
I could go find it and put it in the chat for people if they don't have it on how to swab, unless you want to demonstrate. But
I remember that, and that was useful because it was basically that updated, like make sure you're doing multiple parts and go as far back as you can and all that sort of stuff. Yeah. So there's a question about RSV and flu around and interacting with or affecting SARS-CoV-2 variants. Well, I mean, I don't know that it's affecting the evolution of the new variants, but it certainly could be the case that, as I said, I think I mentioned a couple of ways that they can be interacting. One is co-infection, one or the other making you more susceptible to the opposite infection because of short-term immune function issues or longer-term. So we haven't had this, like, this is different situation where we had COVID, this novel coronavirus tear through the population in the last year, and no respiratory viruses for one of those years. Or I say no respiratory, no RSV and flu for 1 year, essentially no flu for 2 years, and now all this happening at once. I don't know. I mean, that's the point, I think, because we don't know. And so when people are confidently saying, oh, it's just immunity debt, just got to ride it out. Number one, I look at their record. Like, were you right about airborne transmission? Were you right about reinfections? Were you right about new variants? Were you right about, no more waves? And usually, a lot of times they were wrong about all those things. So I think we need to stop assuming we've got a solid handle on this virus. It's changing a lot, and there's a lot of other things going on. So, we need to be very, very careful. I think the rest is links and stuff. So were there any other questions that you...
I thought we should do a poll, although I don't have a poll set up, so we'd have to use our hands. When someone asked how many people in this meeting wear high quality masks properly, I don't know if people want to raise their hands. I would assume many people here.
Part of that is the messaging as well. So, on the one hand, we've got an awful lot of strongly encourage, sometimes it gets up to urge, but the leaders aren't modeling it.
Yeah.
So, I mean, you can look at, there's Moore at a party, and there's Walensky doing a photo op, and there, nobody's modeling it. And there's lots of baggy surgical masks out there, and so I mean, we haven't really tried it as a solid strategy. We haven't distributed N95s. We haven't done training on how to use them and so on. But clean air, like I said, clean air and filtering, whether it's filtering it at a Corsi Rosenthal box or some other filter, or on your face, filtering it on your face. Those are variant proof. So. At least they are not subject to all of these sort of immune escape and transmissibility things and all that stuff. And I would go so far as to say you can't really evolve to get around the physics of an N95. Like, I mean, they just trap particles of a certain size, right?
Yep.
So I think, so I don't know if I see.
I'm just put in a chat for our Raina McIntyre is going to come and talk to us next month. So I wanted to make sure that, yeah, we're really excited about that. So at a little bit later, so she can get up at 6 in the morning and talk to us. It'll be 3 in the afternoon here. Yeah, I think there's some more, links to about the China. I think the one link about the antibiotic shortage, like there's so many other things related
the layers of impact, like so in the West there was a fair bit of China needs to get with the program, or whatever, and it's like I don't think you understand a major labor disruption in China due to illness or long COVID or anything is going to mean for everybody. So even if it's not the antibiotics, which it could be, it might be the bottles. Or it might, like one of the things that happened, it was interesting early in the pandemic was, you remember when you couldn't get flour and you couldn't get eggs and stuff. And it was partly because people were baking a lot, but it was also because there was flour. There just weren't bags of the commercial size. There were the restaurant sort of, industrial size packaging. So it was like, you don't necessarily anticipate some of these things. So I bet you the bottles are made in China. Right, and the packaging and all that stuff, and so a lot of things could be indirectly or directly impacting everyone. And I worry about obviously variant evolution, and I worry about people in China. Like it's I don't think we should have let it rip here, and I hope they don't let it rip there.
I mean, what I'd seen was they were reducing those really stringent precautions, but they were still much more cautious than here.
Well, for sure. And so I don't think they're going to just get rid of everything. I think the issue might be whether if you open that box up and then you can't put it back. But I did read a thing about in Beijing, for example, they're not under strict restrictions, but they're behaving as though they are because they see all these cases, so they're kind of doing it anyway. So maybe it won't tear through. And I did see also the case numbers seem to be coming down again, so maybe they will keep control of it. Maybe they'll say, whoa, the people in China have sacrificed an enormous amount to keep it under control, and we all kind of need to be thankful to an extent. I'm not talking about we need to praise the government. I mean, the people have had to be tested all the time, and they've had to do all these things. It's probably a good thing that there weren't another billion hosts in the last year. But at some point that becomes impossible, I guess, especially if there's pressure from the West. I wish there were, some level of I don't really argue for zero COVID. I think it's pretty unrealistic. I would just like less COVID than this.
Yeah. I was going to ask you, and then we probably should let you go, but if there's anyone that we can think of right now that's got the balanced approach, doing it right, at least, and can
I think
the results. Then, I mean, Southeast Asia maybe.
Yeah, I was going to say Japan. A few places in that region seem to, but they. What's interesting is if you look at the sort of death rates and so on for Japan versus Europe and things, people will say, because it's very low. Japan did really well, better than Canada. Canada did pretty well too, but Japan did really quite well. And people say, well, look, they don't have the same obesity as they do in the UK and the US and Canada and stuff. But it's a very old population. It's one of the oldest, demographically. And that's one of the biggest risk factors. So it's more than just like, oh, well, they don't eat so many cheeseburgers, right? So it's mitigation. It's people are wearing masks and those kinds of things. So I don't know. They haven't had, super strict lockdowns. Maybe they can control border crossings more because it's an island and stuff. But there are places that have done fairly well. New Zealand did really well. It did require pretty strict lockdowns in Australia, and now you sort of see what's happening there once they relax that. So it's not, I don't think it's inevitable that you can, well, let me put it like this. Sometimes the argument is made that New Zealand's still doing pretty well, not as well as they were, but sometimes the argument is made like, well, look, you relaxed the thing and now it's rampant everywhere, just like it was for everybody else. I'm like, yeah, but look at how many deaths there were in those other places in the meantime.
Yeah.
Like you've avoided. Like, I don't, you can look at the calculations on how many people would have died in China if they had the same death rates as the US or the UK, right? Like millions. So,
Yep. And
you know,
person years of life saved
yeah.
or whatever, some of those calculations I think are quite
Yeah.
interesting.
So, I mean, you know, I don't know that we can, there's a whole lot of room in between do nothing and completely lock down forever, right? But people kind of frame it as one of those two things. And I think we can do a lot more than we do. I think, and you know what? I'd be fine with, flu season looks like it's going to be bad this year. It was bad in Australia. Let's implement masks in schools for 2 weeks.
Yeah.
You know what I mean? Like, I'm not talking let's close schools forever. I'm saying maybe we could not have the kids get sick, because half of them are going to miss class anyway if they get sick. So why don't we just not have that? We know it works.
Mm-hmm.
So, you know, I think there's some reasonable steps you could take that aren't, you know, yeah, CR box and all those kinds of things, right? So, I mean, absolutely. Why aren't we doing that?
Yeah.
You know, we insist on clean water.
Yeah, it's really strange that, but yeah, that's my hope is that, I mean, the thing about Japan, I think about their CO2 indicators outside their theaters, right? You don't go into a theater, you can already tell before you walk in, never mind the masking. But I agree that CR boxes are such a fantastic tool, and they work for so many things, that they make our environments healthier for burning wood, or we're cooking with gas, or other things, never mind the viruses. And they're relatively cost effective and easy to you know, maintain and replace. So
well, and CO2 as well. Like, you know, the whole idea about schools and learning and this and that, like low CO2 is also good, right? For cognitive function. I mean, there's just a lot of reasons to clean air isn't just COVID, right? Like, it's I think it's better for every reason to have it. So we could have gone in on that. We could have made it a moonshot and really tried to clean up air in the same way that we did, you know, with water in the past and stuff. But I don't think that's going to happen at this point unless people start realizing we need to do something. And I don't know. The problem is, how severe does it have to get before people recognize that? Like, I think because it's so easy to dismiss now. Anyway,
that's exactly. We used to think, oh, when it gets bad, everyone will wake up and do something.
Well, yeah, we used to think if kids start dying, then they're gonna, you know, but
yeah, that hasn't worked either. So I don't know. It'll be some famous person, I guess, which is sad, but
yeah. So yeah,
hopefully something. But so I do want to thank you very much for joining us, especially back to back with another talk that you're able to come and join us. And Kevin, did you have anything else you wanted to add this afternoon, or?
Just how complimentary the speakers were. You know, Amy were talking about the tools to prevent transmission, and Ryan was talking about, and what was kind of really interesting was looking at the troughs between the peaks and the slope. You know, it's almost like a new metric, like looking at the slope, the gradient.
yeah.
It's kind of a metric moving forward. It's not going away. It's not getting better. It's a lot worse. So we really need to think about cleaning the air so much more now than ever. And I think it was fabulous that Amy was to share her work that allows us to do that. So thanks so much for your presentations.
Amy, did you have any last words you wanted to share with everybody?
Oh, thank you, Ryan, for the great presentation. It was very informative. And I really like how our conversation has all come to how we can use masks to reduce the transmission and how we can improve air quality. I especially like your comment that improving air quality through both ventilation and filtration is not only important to reduce the transmission, it is for the general health and well-being and even for the productivity. So I think it is very important to reinforce this point. And from what I have learned from the different community organizations, I think many people are aware of the problem and they try their best to find solutions to address the current challenge. The issue is really they do not have the resources available or the guidance to support them when they are trying to negotiate with the employer or the landlords. So yeah, this is a problem we need to continue working on and hopefully improve one day.
Well, I think it also, from what it sounds like, you know, interdisciplinarity and bringing different kinds of expertise together, as you've been doing, it sounds like with this series, is critical to doing that. You know, and that's one issue I think has been problematic is that, you know, again, various experts really want to dismiss engineering. They want to talk about vaccines only, or pitting, you know, engineering solutions versus, you know, pharmaceutical ones. And I'm like, why aren't you just trying to do all of that? Like, why aren't you working together, right? Like it's not going to be one or the other. And I get very frustrated when most of the messaging is get boosted. That's your best defense. I'm like, no, it isn't actually.
Yeah. Heather asks a good question, I guess, at the end here. How do we educate the politicians to the severity of the lows of that graph, right?
I don't know. I mean, I don't know that a lot of them. Sometimes I don't know whether they don't get it or they just
don't want to
refuse to. Like they're not even going to do it. It is alarming in some ways that you know, Twitter is kind of the only place in some ways that you hear anything. Like sometimes I'll say, you know, there's still variants. Oh, I thought that was it. You're like, oh, there's like massive amounts of, you know, people, because it's not being reported. So what I try to do is you know, really try to support any journalists or others who are talking about it.
Mm-hmm.
Because like someone's got to get some message out. I guess not, you know, but anyway.
And support those media outlets too that are telling the truth, I think.
Yeah, exactly.
Yeah.
Yeah.
Okay, thanks very much, everybody. This will wrap it up so you can enjoy the rest of your weekend and your day. Come back. We are hoping to do a session in mid-January, but we don't about long COVID, so we'll be back to you about that. And then in January 27th, as we said, we've got Raina McIntyre talking about Dark Winter, which is her book about the history of pandemics, but then through the lens of this one and what it tells us about what we need to do to keep striving for transmission reduction and boosting health. So as I said before, the Facebook Live will render on the Facebook page right away. So the video is available if anyone wants to watch it again over the weekend. And then we will post the videos on our YouTube page, and you'll be able to see it again. Ryan, can I ask you for your slides, and we'll post those too, if that's okay. And we already have
sure.
Amy and Amy. So, and I did put in a link to the World Health Network, has some good posters about it. It was actually from last year, but still completely applicable, about steps for a healthy and safe holiday, and you know, getting vaccinated and then testing in the morning and testing before you to go to dinner, and a variety of other strategies, including air cleaning and ventilation. So hopefully everyone can apply those and have a healthy and safe holiday, and we'll see you next year. Thanks again.
Cheers, everyone. Bye-bye.
Bye-bye.
Thank you. Bye.
I'm just trying to figure out how to stop this.